All right, good morning, everyone. I realize we still have a few folks trickling in, but we're going to go ahead and get started because we have 5 excellent presentations for you this morning. This is not the slide I'm looking for. This is our disclaimer, and welcome to Improving Access and Decreasing Costs of Care. My name's Dee Dee Jennings. I'm a social worker at UVA Health, and I'm delighted to be co-moderating with Jamie Wooldridge, who's a professor at University of Rochester Medical Center. We have no disclosures related to this session, and this session will give a taste of the work happening in the U.S. and around the world to improve access to care and decrease cost of care and medications for people with CF. Barriers to care and disadvantages experienced by many different populations will also be addressed, and these presentations discuss valuable insights that CF care teams can utilize to implement improvements at their own center. We have 3 session objectives here, and I do just want to note, because we have 5 presentations, if you're anything like me, you will forget all of your excellent questions for the first presentation by the end. So we actually are going to have a very brief Q&A after each presentation. So feel free to go ahead and open the app and start using the Q&A as you think of things, because we're going to have a little brief Q&A after each one, and then we'll have kind of more time at the end because often there's overlap between topics. So please use that Q&A function in the app whenever you think of something. And I'll hand it off to Jamie to talk, or do you want me to?
Go ahead.
Okay. So we have 5 presentations for you today. The first is barriers that prevent healthcare professionals from asking about and addressing financial needs or social determinants of health by Erica Van Sitters. And I just wanted to note, there were so many excellent abstracts that we could have chosen from for presentation. We were spoiled for choice. We could have easily picked like 20 options. So for each of these, we just quickly noted there are other posters to review, and there's a lot of really excellent work happening. So if you're excited by this session, please go and check out these other things as well. Next, we have impact of an integrated health system specialty pharmacy on clinical and operational outcomes in patients with cystic fibrosis. Then we'll have identifying CF programs in the U.S. with disproportionately disadvantaged patient populations, methodology and implications for care. Exploring the lived experiences of Black and Hispanic Latino people with CF, insights from qualitative interviews. And we're excited to end with our international discussion, building a Pan-African collaborative network for cystic fibrosis, early lessons and shared priorities. So with that in mind, we hope you enjoy the conference, and I'll ask our first speaker to come on up.
Thanks. Welcome. Early in the morning, and I really appreciate you guys being here, and thanks for inviting me to present our work. What I'm going to talk about are barriers that prevent healthcare professionals from asking about and addressing financial needs related to the cost of CF and social determinants of health. And this work has been done in partnership with colleagues across the country. It's been funded by the Cystic Fibrosis Foundation, but that's my only disclosure. All right, so just to begin, I think these are things that you probably already know, but financial issues caused by CF medical bills are common in people with CF and their families. And some of our recent work suggests that 2/3 of people with CF have one or more financial issue that's caused by CF medical bills. And these include things like putting off major purchases, increasing their credit card debt, being unable to save money, using up all or most of their savings, taking on an extra job, working extra hours, and the list goes on and on. We also know that these financial challenges impact their daily living decisions and their healthcare decisions, and find that 29% of people with CF report that they delay or make trade-offs in how they take their medications, and 25% report delays or trade-offs in their daily care. So these are important issues that are common and that should be addressed. And care team members play an important role in addressing this, and we know this. So we know that the majority of care team members think that they have a role in discussing costs of care, and most are comfortable discussing these issues Yet despite that, less than half regularly report that they regularly discuss costs of care with patients in the past year. And so these issues kind of set us up to look at understanding why does this happen and how might we go about addressing that. So the objective of our study was to understand barriers that CF care team members face in asking about social determinants of health and financial needs related to the cost of care, in addressing these needs, and in learning about resources on how they might address these needs. So the data that I'm going to talk about today comes from the COST CF study. This is the cystic fibrosis outcomes, social needs, and trade-offs due to coverage and financial burden. The survey was co-designed by people with CF, caregivers, clinicians, and researchers. And looking across the room, there's several of our co-designers in the midst. And it was really designed to look at what happens over the past year. The intended audience, well, the whole COST CF study is quite big, includes patients and families, but the intended audience for this component are care team members who are working in the United States. The survey was in the field from February to May of 2024, and we had 247 care team members complete the survey. These respondents were broken out primarily by social workers and medical providers included physicians, nurse practitioners, advanced practice registered nurses, and physician assistants. And then we had 10% of pharmacists, 9% with registered nurses, and then our other group included pharmacy technicians, therapists, dietitians, and mental health specialists. All right, so the first area we wanted to understand was, what are the barriers that people face in asking about and addressing social determinants of health and financial needs related to the cost of CF care? And what we found, and it's probably not that surprising, is that the three biggest areas are lack of time, lack of training on how someone might respond to social determinants of health or financial needs that are identified, and the lack of available resources to address these needs. We were interested if there were differences by different disciplines and how, like the training and their assignments of care. And what we find is that these areas in green are common across disciplines. So medical providers, social workers, dietitians, pharmacists, and other providers all face similar barriers in not having enough time to ask, not having enough resources to address both of these types of needs, and so on. And we also found that social workers were less likely than other providers to have barriers in several areas. One of these is the lack of training about how to respond to financial needs. So you'll see that the social workers here are in orange, and the other providers are in medical providers in dark green, pharmacists in blue, registered nurses in light green, and other providers in purple. But social workers are less likely than all these other groups to have barriers around training, comfort asking or discussing, and being outside of their scope of practice. It's not really that surprising given how care teams are set up. When asked who actually is responsible or has designated time for addressing these issues, the vast majority of respondents said it's their social worker. And interestingly, on the far right, you'll see that 20 to 25% said no one, or I really don't know who's responsible at my care center to address these. Given kind of the high proportion of people who say that social workers are the ones who are responsible, it's notable that still 50% of social workers who are taking the survey say they don't have enough time to actually talk about these issues with their patients. So we then wanted to look at, once you ask and you identify a need, are there resources that people can turn to be able to address those issues? And so we first looked at how easy is it or how difficult is it to access resources? And what we're showing here in the green are people who say that it's not at all easy to access these resources, and in gray that's saying these resources simply aren't available where they are. And what you see is the vast majority, well, nearly 50% of people say that they can't access resources around housing insecurity. 30 to 40% say they can't access resources around employment needs, and 20 to 25% can't access resources around health insurance literacy or medical bills, health literacy, utility needs, and so on. And moving one step further, we looked at how effective are these resources. So if they can access them, then how effective are they? And here again, you see in purple, the people saying that they're not at all effective, and in gray saying those resources aren't available. The denominator changes between these two groups, which is why the gray, I think, gets a little bigger. But what we find is that even if they are available, the effectiveness of resources right now to address particularly housing insecurity, employment needs, health insurance literacy, and health literacy really aren't seen as effective at all by care team members. So just kind of moving forward, the primary barriers that people identify in asking about and addressing social determinants of health and financial needs related to the cost of care are the lack of resources. And we tried to illustrate these with quotes. So here's one social worker saying, "There's no resources available for many financial challenges, especially chronically low resource families. It's frustrating for families to be screened, but to have no resources available." And then the second biggest issue is around staff time to actually address these issues, kind of the time of visits and ability of social workers to be at appointments. So then we wanted to understand, so if these are issues, what are teams doing right now to address them? How are they going about finding resources to be able to address these issues? Where do they learn about those resources, and are there opportunities that we can tap into there? So what we found is that most of our respondents to the survey are unaware of training resources for educating care team members about how to address social determinants of health, or how to address the financial needs related to the cost of CF care. And so here you can see that 27% aren't sure where they'd go to find these resources. 41% say they're not aware. So that's about 68% really don't know how to access these materials. And then of those that are accessing them, most of them are going to the CF Foundation or other resources. And it's a similar picture for financial needs with a little bit less knowledge about how you might go about finding these resources overall. And we then kind of dove one step deeper, which was to say, if you are going to find these, where are you actually finding resources? How are you getting this information? And we found is that most people are talking to their team members, so their peers, their colleagues, about where are these resources, how do we access them? That's followed by the CF Foundation, then online, and local resources. There's a number of other categories, but they were significantly less likely to be endorsed here. So we just pulled a couple quotes from this. "I utilize the knowledge of our social worker and medication liaison to access resources. I find myself Googling information about this almost every day, and I use information I obtain from various sources across the internet. And finally, I have a spreadsheet or resources that I have maintained and updated throughout the years. I ask social work colleagues within CF and outside CF. I research and or call public agencies." So a variety of different methods, and I think it's important to think about. So just kind of in summary, what we're finding, right, is that there are a number of barriers that people face in asking about and addressing social determinants of health and financial needs related to the cost of care. And people don't necessarily know where to go to get resources to address these things. And so we asked for recommendations, and they came really around 4 big areas. One of them is standardized processes. And this comes, like an example is, it would be helpful if we created a unified questionnaire and a CF-specific resource list to help address these issues or these areas of social determinants of health. Another bucket is around having more resources available. So having more resources available, especially financial or community-oriented resources. The third is on training, and a number of different areas were identified as important to people with to care team members. This included webinars, videos, worksheets that people could go to, presentations at NACFC, and a number of other areas. Kind of wrapped it up in, if we want all care team members to be knowledgeable, not just the social worker, then it needs to be addressed by CFF as a whole and have webinars or classes available, maybe at NACFC. And then finally, time really cuts across all the areas, and I just chose one, but there's 60 different responses to each of these questions that is almost the same in each of these categories. But again, more time, more education, and more resources. So in summary, barriers to asking about and addressing social determinants of health and financial needs related to the cost of care are common. The most common include time, a lack of time, lack of training, and lack of accessible and effective resources. These barriers are pervasive across disciplines, with the exception that social workers report fewer barriers in training, in comfort, and in alignment with what their actual jobs look like. And there's limited awareness of how people might get educated about these different resources that exist and how they could address needs. So moving forward, we have a number of recommendations that we think could be helpful. And these are really coming again from what our care team members are saying in response to many of these open-ended questions. But standardized tools and processes to assess needs, greater availability of effective and accessible resources, automated processes to connect people with CF to these resources, multimodal education resources, and sufficient staff time that's allocated to addressing these needs. So in summary, thanks to all the CF care team members that completed this survey. We really appreciate your input. And thanks to the co-design team who helped put this together. That's it. Any questions? Any questions or thoughts?
Sorry, I'm making you walk all the way over to me.
ICE. So we're in California, and we have to, they can't go out to the fields to work. They can't go into restaurants to work. And this is not just California. This is Chicago, Virginia, everywhere. So I know the CF Foundation is a little nervous about DEI right now, but can we add that in terms of how we approach? We have standardized handouts we give people. We do telemedicine visits now rather than have to, so they don't have to leave the house.
Yeah, I think that's an important thing. I have several colleagues from the CF Foundation who have been partners in this work. I don't know if any of you want to be able to address that or comment.
So is the question how to repurpose? I'm not quite sure what you're asking us.
Your work is only half done.
Yes, thanks. I mean, I think, so the other thing I would say is in looking at these responses, it's really clear that there is work that's just been started. And so a lot of programs said, our social worker is just starting to be put in place. We're just starting to get here and we recognize these processes aren't in place. So there's this, I would be really curious to see what this looks like in a year. I mean, it's already been a year and a half. What does this look like now? What does it look like in 6 months from now? And are these processes starting to actually be put in place? Because a year and a half ago, that's where it said, we just got our social worker. We're starting to do this. I think it's a really important issue and it's going to be increasingly important. And I think it's something that the CF Foundation has really placed an emphasis on and will continue to do so. So thanks for the comment. Any other comments, thoughts?
I'm just kind of curious. You had a lot of people who thought that it was ineffective or not easily accessible. How many people actually interacted with these entities? Have tried to access housing for someone that indicated they were housing insecure?
Yeah. So that's a great question. I'm trying to think if we asked it specifically. I anticipate that the greatest proportion of those people who are asking are your social workers, right? And so that would naturally increase the rate because you would have physicians who may say, I'm not aware. So I think that's where you get a lot of that coming from. But I still think there are these there are these common barriers that cut across all of these different pieces. And so I think that's important for us to recognize that regardless of discipline, you're still facing challenges around time, ability to access resources, and forgot the third one right now. Sorry. But anyway, you're still facing these common barriers regardless of your discipline. And one of those was the inability to access resources. And so I think that still says this is an issue. There isn't a difference between your social workers, your physicians, your other types of providers in accessing those resources. And so just like, while it might look a little bit elevated, I think given the lack of difference there, I think it is an issue that is probably continues to be faced by those people who have designated time and responsibility for addressing it. Does that answer your question? Yeah. Okay. Any other questions
hear
or
me?
thoughts?
Can everybody hear me? Okay. So I'll just add to that comment. So I'm in New York, and New York has, the state government put together about $5 billion to create what they call social care networks based on region to help Medicaid patients. And it's not just people with CF, it's all Medicaid patients with social determinants of health. And I will tell you that we are halfway through that 3-year grant, and the number of people that have been helped is very small because each organization, even though they have the money, they're finding nobody wants to do the work, or they don't want to set up a contract to do the work before they're actually know they've got clients, so they don't want to commit to work when they've got other work to go do. And even these organizations themselves are having difficulty getting the information out to even how to resource them. So it really is, like in the state of New York, the money is there, but setting up the infrastructure, and there's a lot of fear we're going to lose this money because we're not going to be set up within the 3-year time limit.
Any other questions?
We've got a question from the end. We've got one question from the app here for you, Erica. It says, regarding, and since I'm a social worker, I love this question. Regarding lack of time for social workers, did anyone mention how much time they would need to address health-related social needs? Alternatively, do you have any recommendations for how much time would be needed?
Boy, no, they didn't. I'm just trying, in my head, I'm thinking through all these qualitative responses that I have just reread over. There wasn't anybody who said, I need like this, but I think that there were different responses in terms of how fully funded they are with respect to FTEs and how many people they're serving on a single FTE or on a 0.5 FTE, and just saying that it's an insufficient. So I think part of what may need to happen is looking at what is the ratio of what should be, and maybe it already has happened, but social worker to population size, how much can you handle? And then what are all the other responsibilities that they're taking care of at the same time that they have to make a trade-off between addressing the financial needs or mental health needs or other needs in their realm of responsibility. So I think those are some of the comments that came out that related to that.
That's great. Yeah.
Perfect.
I think we need to get moving
Awesome.
forward.
Thank you, guys.
Okay. Who's our next one? Because it's not listed.
I believe it's Kubiak.
Okay.
Yeah. Sarah.
Sarah, you're listening. Okay. Okay, so I'm happy to introduce Sarah Kubiak, who's going to present on impact of integrated health systems, specialty pharmacy, on clinical and operational outcomes in people with CF.
Thank you.
Good morning, everyone. Thank you so much for inviting me here today to share this project that is very near and dear to my heart. So today I'll be presenting on the assessed impact of an integrated health system specialty pharmacy on clinical and operational outcomes in patients with CF at Boston Children's Hospital. No disclosures for today. And we'll follow the usual order of info of the project. So we all know that CF is a complex chronic disease that requires comprehensive multidisciplinary care, and timely access to therapies, medication adherence, and ongoing monitoring are crucial components to ensure positive patient outcomes. Given the increasing complexity of CF medication management, in 2024, the CF Foundation added pharmacists as core members of the CF care team. Hospital integrated or health system specialty pharmacies can further enhance and streamline care coordination amongst pharmacists, providers, clinic staff, and patients. And multiple studies have demonstrated that this service benefits both patients and hospitals, with improved medication access, cost savings, and improved clinical outcomes for patients with CF. In the integrated HSSP pharmacy model, the clinic's pharmacist and pharmacy technician work alongside the patient and care team to complete prior authorizations and financial assistance applications. Once medication coverage is secured, the pharmacist provides medication counseling to the patient and initiates a medication management plan to ensure that therapies are monitored for safety and efficacy. And many of these services take place while the patient is still being seen at their clinic visit. The hospital pharmacy then dispenses the medication to the patient, and the clinic's pharmacy tech provides monthly refill reminders and delivery coordination, while the clinic pharmacist continues to provide ongoing support to the patient and care team. The HSSP pharmacy team provides ongoing automatic PA and FA renewals as the patient remains on therapy. With a collaborative drug therapy management program, pharmacists can further support care teams by providing comprehensive medication and prescription management, completing documentation of patients' medication management plans and outcomes, participating in interdisciplinary collaboration, and providing medication education to patients. In September of 2023, Boston Children's Hospital opened a hospital-integrated specialty pharmacy, and the first clinics serviced through the HSSP CDTM model were the CF clinics. The purpose of our study is to assess the impact of an integrated health system specialty pharmacy with a pharmacist-led CDTM program on operational outcomes, medication adherence, and clinical outcomes in patients with CF at BCH. Our study is a single-center retrospective observational cohort approved by the hospital's IRB and includes patients from our CF center who filled specialty medications through the integrated hospital specialty pharmacy and were enrolled in the pharmacist CDTM program from September 2023 to September 2024. Patients were identified by prescription refill records, and descriptive statistics were used to analyze the data. Our primary endpoint was time to medication initiation for New Start patients, defined as the duration from prescription receipt at the hospital's specialty pharmacy to the first dispense of the medication. Our secondary endpoints include medication adherence as assessed by proportion of days covered, operational metrics such as submission and approval of prior authorization, enrollment in financial assistance programs, and patient out-of-pocket costs. Clinical outcomes were also assessed, as well as patient-reported outcomes of perceived treatment efficacy and factors affecting quality of life, such as missed days of work, school, and planned activities. 191 patients were included in this analysis, with 59% being over the age of 18 and 41% being under the age of 18, with an overall average age of 23 years. Our patient demographic data is somewhat limited by our EMR records, as the study's time period included a transition from Cerner to Epic. But our cohort overall seems to be well matched to our CF Center's patient demographics. 46% of our patients were filling with a commercial insurance plan, while 54% of our patients had prescription coverage from a Medicaid or Medicare plan. The majority of prescriptions dispensed during the study time were for CFTR modulators, namely elexacaftor, tezacaftor, and ivacaftor. And other specialty medications dispensed include nebulized Dornase alpha, nebulized tobramycin, pancreatic enzymes, and other modulators such as ivacaftor, tez-ivacaftor, and lumacaftor ivacaftor. Most patients were filling one medication at the hospital specialty pharmacy, but we did have some patients filling 2, 3, and up to 4 medications. With our HSSP CDTM model, 29% of patients were able to receive their specialty medication the same day that it was prescribed. 38% of our patients received their medication within 1 to 2 days of prescription receipt. 90% of our patients had adherence rates of 70% or above, with the majority of patients having adherence rates of 90% or above. Our HSSP pharmacy team was able to achieve PA approval rates of 96%. 51% of our patients qualified for financial assistance programs, and 100% of our patients who qualified for FA were enrolled by our team. The average out-of-pocket cost per prescription filled during this time frame was $5.14, with 91% of our prescriptions having a zero out-of-pocket cost for patients. 99% of our patients reported treatment efficacy of well or very well, and 89% of our patients reported not missing work, school, or planned activities due to their disease state during this time period. Of the 191 patients with CF utilizing the hospital pharmacy during the year time period, there were a total of 8 pulmonary exacerbations, which resulted in 3 ED visits and 5 hospitalizations. We don't really have a comparator here, but this is around 4% of patients who experienced an exacerbation within the year, where our current national value for patients who experience 1 or more exacerbations in 2024, according to registry data, is 8.7% for patients less than 18 years and 14.5% for patients 18 years and older. Of course, exacerbation rates are highly dependent on patients' baseline disease state characteristics, which are not analyzed here. Our overall findings were that the HSSP CDTM model resulted in improved access to CF specialty medications, with the majority of our patients receiving their medication either same day or within 1 to 2 days of prescription receipt, where the national average turnaround time is 6 to 10 days. Our patients demonstrated high adherence rates with low rates of exacerbations and hospitalizations. Quality of life measures were positive, and financial barriers to treatment were minimized. Due to our model's robust PA and FA system, 91% of our patients had a zero out-of-pocket cost for their medications. So while our patient outcomes were positive, I do want to point out that many of our patients at our CF center are unable to utilize the integrated hospital pharmacy due to insurance lockouts and manufacturer access restrictions, namely for CFTR modulators. Drug manufacturers and PBMs need to recognize that these restrictions may negatively impact patient outcomes. So in light of the positive outcome seen with our HSSP CDTM model for patients with CF, we have since expanded the service to now include 5 other disease state clinics at BCH, and we also have expanded the medications provided by our hospital pharmacy to include all retail medications, in addition to specialty medications, so that patients have the opportunity for comprehensive medication support and pharmacy consolidation. We do plan to continue to assess outcomes data for our patients in an effort to encourage PBMs and drug manufacturers to allow patients the options of filling at the hospital integrated pharmacy if they choose. And thank you. Can I open it up for questions?
Yes.
Yeah. Okay.
Oh,
Hoping I can get a great work. And
Yes.
We're thrilled to have you as part of our team. But I'm wondering if you could comment a little bit more about why some families are not able to access the services. Like, what are the reasons that are given?
Sure.
You know, how is it certain payers, like national payers? Does it cluster around, you know, can you identify any patterns of sort of where advocacy ever seems to move to sort of make their policy change?
Yeah, so there are some insurance companies that have contracts with the corporation specialty pharmacies, and they restrict patients to only fill at that specialty pharmacy. And also in terms of drug manufacturers with the limited drug distribution program, many manufacturers will only allow 340B access to hospital pharmacies. And there's a lot of rules and restrictions around 340B. And basically in Massachusetts, all of our Medicaid patients do not qualify and cannot get modulators at our CF center.
Hi, yeah, I just wanted to clarify. So in other words, this is a 340B pharmacy.
Yes.
Okay, yeah. And did you just say that in Massachusetts, Medicaid patients can't use your 340B?
Correct. Yeah, it's Massachusetts carve out for 340B.
So it's obviously very individually dependent because a lot of, yeah, I mean, across the country, 340Bs, you know, a lot of them don't cover any outpatient. It's very, I mean, so it's great. In other words, if your 340B can work.
Correct. Yeah.
Thank you.
Hi, my question is, it's kind of like a real world question in the sense of The biggest challenge I have seen and observed within my cohort of cystic fibrosis patients is the time between requesting the medication and getting the medication. And my background is fairly technical. So I've worked for Department of Health in these very problems for almost 28 years. So I think that's TAT is your big one there. I mean, you really got to improve that. And I saw that you kind of you truncated your timeline in terms of the request to, like I might even get a prescription until my third party payer or my health insurer covers it, then the prescription, then the. But what I'm very interested in, and I think a lot of CF patients are interested in, is I make the request. When do I get the medication? Not just for Trikafta or LF-Trikafta, but like for diabetes medication, for like all of it, right? And I think this could be incredible, with the 340B exception, which I think is, that's hard to explain for me, but I think I would want to extend those time frames just to see how, because one of my fears is that medical adherence is not entirely a function of volitionally, like a choice on the part of the patient, but medical adherence, and we used to do this at DOH all the time. We used to look at the billings across 12 months and be like, it's about 6 weeks, no billings, and it's like, it's not the patient's fault.
Right.
Yeah. And with CF, it's definitely not, because CF is like, adherence is everything. I mean, you take Trikafta and then you don't take Trikafta for 3 months, outcomes are impacted, right?
I think looking at lapses in therapy is a good metric.
Yeah, I mean, it's really good. Look at your billings data. I mean, that's what I would highly suggest. Like I had access to it for, quarter century. And whenever we ask these questions, and not just for CF, because actually I had to recuse myself from CF. I did all my analysis, economic analysis on non-CF. But you got to be looking at that stuff. If you really want to know if this is like, and the other thing too I want to know is what percentage does it improve? What were your TATs before?
This was the grand opening of the pharmacy, so we didn't, you
didn't have a baseline.
We didn't have a baseline, but we could compare to patients filling at outside pharmacies.
Yeah, that's true. You could. Yeah, you can find cohorts. Yeah, that's a good idea. That was my only question. I'm just, because I really, my focus was more like very real world. Like, I worked for the Division of Budget and then I worked for Department of Health. Like, so I think those kinds of questions, maybe not from a scientific standpoint, but I think from like a quality of life and quality of patient like experience are extremely important. Because I think all of CF has really come down to it, not all of it. I know we have 90% that are sensitive, but it really has come down to a process issue. Mm-hmm. Mm-hmm. Like most of what's going on in CF that's not research is process.
Right.
For us patients. We don't get those meds, life goes to heck. So I think that's something that I have observed, and I don't think that the system has responded that well at all. TATs are way too long. Yeah. And I've even been told by big CF centers
I'm
that...
sorry, just out of interest of time, we've got
multiple
other people who have questions.
Thank you so much.
I'll just speak up. So thank you for the presentation. Very interested in the integrated component, as you alluded to in the presentation, and the first couple of questions also touched on. This is certainly incumbent on a 340B pharmacy. I'm curious, what components of this do you think are extendable beyond 340B and that closed loop, and where are the limitations? In other words, where is it really necessary to see the benefits to have that integrated 340B pharmacy? Because we're not going to fix the 340B issue anytime soon. It's only mounting in challenges for pharma challenging the utilization of 340B.
So your question is, when does the benefit?
I think it's what's replicable outside and what isn't.
Okay.
Does that make sense?
Yeah. So, generally our hospital pharmacy does have access to most medications non-340B. Modulators are really the only exception for our pharmacy. So I think until we can really have full access to modulators, it's hard to really estimate that.
We take up to 6 hours. And so I keep trying to for 35 years, persuade our institution that 6 hours of nursing time, bring in a pharmacist how did you go about doing that in terms of your quality improvement inside the hospital? How did you establish your pharmacy?
So the hospital pharmacy has been in the works for a while. I was able to get into my role to, help open the specialty pharmacy through the CF Foundation. They offered a grant for pharmacists implementing pharmacy services in the outpatient clinic. So that was really the kicker of what started everything off. Yeah, well, it comes every year, so.
Yeah, so we've got time for one more question.
Hello. I'm biased. I work at Boston Children's. I wanted to give an anecdote as a social worker that Sarah and our pharmacy liaison are I don't know what we did without them. They are angels. And as a social worker, looking back at Erica's talk, how do I find time to do all the things? When a patient calls me and says, I'm having issues I just had a $2,000 copay. I'm like, oh, let me connect you with Sarah and Michelle. And then I can do the other things. We have patients who are getting medications prescribed through other hospital systems for diabetes, and they're not billed correctly. They are not getting their medications. And I send them to Sarah and Michelle, and they're like, we'll take care of it. And then they're in-house with us. And so they're making sure they're getting all their medications, not just a specialty pharmacy. So it has been a godsend to have you guys. And so there's impacts beyond what Sarah's talking about today that I think is really important to highlight.
Thanks,
Thank you. Thank you.
I'm delighted to introduce Dr. Gabriella Oates for our next presentation.
Thank you for having me here. It's so lovely to see so many of you that I know, including my main collaborators on this work, the two Elizabeths, Dr. Baker and Dr. Cromwell. Nothing to disclose in relation to this presentation, but I will talk to you about how we developed a methodology to identify programs with disproportionate mainly disadvantaged patients, and why this is important. So it's no secret that providing care for patients who are socioeconomically disadvantaged or live in rural areas is more costly. What is really, really important is how this affects CF care. And all I need to do is remind you what we just discussed in the past 30 minutes. If you have two CF programs with identical number of patients, identical FTEs for social work, diabetes, etc., but one of them has 5% with those unmet needs, and the other has 50% of patients with such needs. Tell me what happens. The burden, the pressure on the CF care team to find resources, identify the resources, link patients to these resources is enormous. And very often it's not reimbursable. How do you reimburse like the 6 hours of phone calls made to find food for one family? So that's why we thought it's really, really important to find a way to identify those programs in the U.S. that do serve a disproportionate number of such disadvantaged patients. Why? Because these are the programs that actually may benefit from either additional resources or some novel approaches to how we deliver care. So we wanted to develop a methodology that's reliable, it's replicable, that we could share with the CF Foundation so it can be used going forward. And these metrics then could be incorporated by the foundation to support CF care delivery. Now, the problem is that the very good metrics of socioeconomic disadvantage, for example, income, education, and occupation that are available in the CF patient registry are either somewhat limited, they have a high level of missingness. So we decided that we need to supplement the patient registry data with metrics from other data sources, publicly available data sources. So what we did, we used simultaneously 3 area level measures. So measures of disadvantage on the level of neighborhoods, not necessarily of CF patients. We used the social vulnerability index, the area deprivation index, and a measure of rurality. These are national composite indices that are calculated based on multiple variables. For example, the SVI includes 16 variables grouped into 4 thematic domains. And area deprivation index includes 17. They are measured at different geographic scales. The SVI at the level of tracts, the ADI at the level of block groups or the even smaller areas. And rurality is measured by the Federal Office for Rural Health Policy based on the proportion of population residing in rural tracts. And this is a comparison of the 3 different measures that we used. You will see highlighted in green the overlapping variables. So there is quite a bit of overlap that we accounted for. And in terms of SVI, we really focused on the socioeconomic status theme. Now, the problem is, for those of you who know, is that in the patient registry, we do not have addresses, so we can't bring those metrics from those very granular geographic area levels. So we had to aggregate everything to the level of the zip code, which is the only metric available in the registry. So we very carefully averaged block groups to tracts to zip codes using weighted averages for more accurate assessment. And then what we did, we linked all of these measures to patient registry data for each year for 8-year span from 2015 to 2022. We also wanted to know what happens, how often people may be changing addresses, so that affects their zip code. So we did some exploratory analyses to determine the stability of our data over time. And we did find that 40% of people do change zip codes in this 8-year period, but in terms of disadvantage, this move is lateral. Yes, you may move, but you don't go up or down. You're sort of socioeconomically, you just move into a comparable neighborhood. And we explored multiple versions of the indices over time, including interactions between them and rurality. We also looked at those individual patient level markers that we talked about, education, income, and health insurance type. We could not include them in our metrics. Education is extremely useful in the pediatric population because it pulls the education of the parents. When you move to the adults with CF, particularly in the group of like 19 to 26, 30-year-old, it becomes very unreliable. Same with income, very high missingness, but our analyses show that it's very highly correlated with both indices, so we're good with using them instead. We did use health insurance type. So how did we define disadvantage? On the level of patients, we included 4 markers. The weighted SVI on the zip code level, weighted ADI, rural zip code, and only public or no health insurance. We use different cutoffs for the indices to ensure that the sample designed as disadvantaged in either way is comparable in size and meaning. I will go into this a little bit later. There is a big problem with the ADI. It includes 16 variables, but it was not standardized. So the variables with the higher value, which is what property values and income, they're actually disproportionately weighted. What does that mean? If you live in a rural area or in a state where incomes are generally lower, if you live in a metro area, you may be disadvantaged. The index does not capture it well. So then we ranked the programs by the proportion of the disadvantaged patients as we just defined. again in 4 different ways. The programs that we focused on the worst quintile or the worst 20% of programs in 4 different ways. Those that meet all 3 criteria, ADI, SVI, and public no insurance. Those that meet 2 criteria, ADI and SVI. Those that meet ADI and no insurance or public insurance and SVI and public no insurance. We wanted to see what do we get if we define disadvantage differently. And we get very interesting results. We had more than 41,000 unique people with CF in the analyses, more than 250,000 records for the 8-year period. There were 303 programs altogether, but the number varies annually because, some programs come and go. The rest is familiar to you. About half of them are in pediatric and less than 5% in affiliate programs. Now, I'm going to present 4 slides with the 4 different methods. If you rank CF programs relative to each other based on the proportion of disadvantaged people by this first method, that they meet all of the 3 criteria, you end up with 7 programs, 5 pediatric, 1 adult, and 1 affiliate. And they are mostly in the South, geographically. If you use the other classification with just the 2 indices, ADI and SVI, again, you get 7 programs, but they're a bit more balanced. 2 pediatric, 3 adult, 2 affiliate. Again, mostly South. If you focused on ADI and public or no insurance, the sample expands. We have 12 programs, 8 pediatric, 2 adult, 2 affiliate. Geographically way better distributed, South, Midwest, and a bit of a Northeast. And then if you only look at SVI and the public insurance, you end up with 15, 10 pediatric, 1 adult, 4 affiliate. So these patterns, geographic patterns, are illustrated here with the 4 different methods. The darker color indicates higher number of disadvantaged programs. Yes, the South is there no matter what you do, but you will see that the only method of classification that picks up disadvantage in the West and in Midwest is when you use the SVI and the public or no insurance. So this confirmed what we had already known, that ADI captures disadvantage better in more rural areas and SVI in more urban areas. It was really important because a lot of our population actually, particularly the adult population, lives more in the metro areas. We also found that those scores change with each new release of the indices, which means those rankings and scores need to be recalculated, if not every year, then at least every other year. And we have shared all our code in everything that that's needed for this analysis with the CF Foundation, so they could independently do that going forward. We also as well-known, found that public health insurance is more available to the under 18 population. So when programs are ranked by disadvantage, they really need to be ranked differently, the pediatric centers from the adult centers. So in summary, we did develop the methodology to identify programs that serve a disproportionately high number of patients who are economically disadvantaged, in order for them to be highlighted and picked up for additional research or interventions, opportunities to improve care delivery or supplemental funding if available. I can't stress enough how critical this is, particularly in the context of our recently weakened social safety net program and system with limited access to insurance and food and any other social program. However, disadvantage is not unique to the U.S. So I do believe also, because we also have an international presentation, that these approaches also need to be looked at outside of the U.S. and other regions. And finally, acknowledging the support of the CF Foundation for this work. And this paper was recently published, so if you want to learn more about the methodology, it's available in the Journal of Cystic Fibrosis. Thank you.
Thank you. So we've got a bit of time for questions, but I'm going to ask everyone to come over. They made us stand so that you don't have to watch me run around and get my steps in anymore.
Hi, I'm Kathy Ramos from University of Washington. Great presentation, really interesting. I'm kind of wondering two things. One, how much overlap was there for the individual programs that were identified with all of the different methodologies?
Zero.
Based on how we did it.
Based on how we did it, zero. These are unique programs.
Okay, so interesting. So depending on the methodology, a program that is disadvantaged in one of these is
It's not in the
completely
others.
mixed.
They're completely dependent. 7, 7, 12, 15, when you group them together, these 30 or whatever, they're unique programs.
That's really interesting. That's where it's
Like the ones that are disadvantaged in all three are the overlap.
okay. All right, that makes sense. And then did you look at clinical outcomes for the disadvantaged groups, things like nutrition and FEV1 and that kind of?
So great question. No, we did not. We're very laser focused on developing the methodology. I totally acknowledge it needs to be done.
Great. Next steps.
Gabriella, Greg Sawicki in Boston. This is fantastic work and so important. And I have two questions. One is, it's clear that there are regional differences in the U.S. where there are going to be programs in certain parts of the U.S. that have a higher proportion of disadvantaged individuals. And you probably could have predicted that based on sort of the normal socio-demographics. But I'm curious that within a region, how much variability there is. So, for instance, if you just looked at the South, are there programs that never fall into having a high level of disadvantaged patients? And, can we?
Totally.
And so I guess the question then is, I'm just going to choose your state of Alabama, for instance. If you had, let's say, hypothetically, 4 programs in Alabama that had, and one serves more disadvantage and one doesn't, like, why does that happen? Is there a reason to sort of structurally try to address that at a regional approach?
That's a really interesting question. We actually did not have that many programs, particularly in the South, so multiple programs within a state. With my state of Alabama, we have 1 program, but my program only appeared once. In any of these 4 classifications and 4 different methods, this program was only disadvantaged in one of the methods and not the other 3. I don't know if we have that many down there because we're so rural that we have more than 1 per state to answer this question, but let me look into it and get back with you.
I think that gets to my second question, which is now putting on my hat as a center director. If I were to get this data for my center or comparator around sort of, regionally or nationally, I guess my question is, what would you recommend that, center directors do with this kind of data? I mean, how is it, I think a lot of us can say, we talk to our team and we get a sense of, who are our at-risk populations, and we feel like we have a higher level of at-risk populations or not. But I think understanding how our population compares to others might be helpful. But at the same time, I worry that this kind of data might be very confusing. And so I guess the question is, how do you action this into something that might help people who are on the ground running these clinics?
Not being a center director or a clinician at all, just take this with a grain of salt. But if I imagined myself to be a center director, I would pull a data for comparable center, the same number of patients, same size of clinical team, and I'll say, we provide all of these extra care to 50 more patients than so-and-so center. We need more FT for social work, more FT for a dietitian. We just need more resources in terms of staffing. Whether this comes from the foundation, whether this comes from your institution, I don't know, but I would strongly make the case that we provide care for people that just need more man hours, and we don't have them.
Thank you, Chris Lennon and Ventura. We, within Cerner, there's something called Health E. So we do Childhood Opportunity Index, Air Deprivation Index on everyone. And because we have this wildfire urban interface, we also do Air Quality Index, which helps pick things up. When I tried to do this with the Next Generation Registry, I think we ground them to a halt because it does have to be by address. And we can all do that within our own. You just have to find a student or someone to put in the addresses. So you're doing the right work.
Well, thank you.
But we can as center directors make this a priority It's not that it's some mysterious thing. It's very, very available.
Well, the whole purpose of this work is basically to show that 200 patients here and 200 patients there is not equal. Just looking at the size of the center doesn't tell you enough. It doesn't tell you enough of the kind of people that you give care to.
Hi, Gabriella. This is Jennifer Gimbalat from Arkansas Children's, University of Arkansas. Great talk. And I am not also a center director, but I am a pediatric pulmonologist and a division director. And this kind of alludes back to Greg Suki's question about what do we do with this information. And as a division director, part of my role is to help work with the center director and to get all of these FTEs that are needed. And as we all know, it is very challenging and is getting more challenging by the day. So I just wondered, one, is that the foundation in doing this project thinking, how can we reevaluate how we reallocate resources? Are there any thoughts to what they might do for some of the programs that have these higher needs? They might not necessarily be the largest programs, but they are the programs that have the highest needs for this. But also, too, any thoughts about partnering with local advocacy groups like the American Academy of Pediatrics, or local CF chapters, or other groups to see if there's more advocacy we can do using this information?
Mm-hmm. Great questions. I cannot answer the first one because I do not speak for the CF Foundation. We did have these conversations while drafting the paper, and we're very careful with the language because I cannot commit anything, funds or anything on behalf of the foundation. So I would defer the answer to this question to if there is anybody in the CF Foundation.
I think it's absolutely a question we are considering very closely, and we're really pleased to have this work done.
Thank you. The second question was about local partnering. I'll go back to what Erica said. A lot of this work is in its infancy. The foundation has started great work around screening and developing processes for social determinants of health. I think it's really important what you said. I don't think the work's done. But it has started. What I would like to add is that actually our team is developing the standardized screening tool that Erica mentioned we need. That's very specific to the needs of people with CF, not the general population. That's very pediatric specific versus adult specific. So I hope that next year, this time, we should be able to present that tool. That goes with what you said, partnering with, you can screen, you can identify needs. If there are no resources, you're stuck. And I recognize how important this is and frustrating for team members and for patients. But we do have, the foundation has a great resource in Compass. So looking at beefing this up, using it better, training people better, I think is where the future is.
I think we've got time for one more question right now, and I'll just ask everyone else to put their questions in the app because we'll have a large Q&A at the end.
Great work, by the way. Incredible. I have to really analyze it. Was there any attempt to content validate this against disproportionate share hospital payments to see if what's the uncompensated care, or there's another kind of federal thing where you look at the percentage of Medicaid enrollment in the hospital versus total, or in the clinic versus total, or the other thing too is acuity. I know in New York State they have an APG system which actually we actually have acuity numbers for every patient in every cost center in New York State. And I think if a more sick population, let's say higher BC patient, whatever the factors are, more transplants, that is also going to drive a greater utilization of resources, right? So those are the two thoughts. I know they're kind of next steps, but those are two thoughts I have.
Well, thank you. We have actually not done that. It's a interesting idea. The question would be, how do we get the data? Because it has to be specific to people with CF. I don't know if in the registry we have necessarily cost-related data. We don't. We don't have a national CF registry similar to, say, the cancer registry that has cost data associated with it. So that will take some thinking if it's a next step. And I'm sorry I can't offer anything more. Liz, do you? No.
Thank you so much.
Well, we have to pull individual EMR records of what was like 240,000, like 40,000 people all over the country. I don't want to think what this RB is going to look like. No.
Okay, and then our next speaker is Tiana. If you want to come on up. There we go. Hit start. Who's going to be talking about the lived experiences of Black and Hispanic Latino people with CF?
Thank you so much. I'm Tiana Milanich, and I'm here from Washington. Welcome, and thank you for having me. So I really want to just take this moment to highlight and feature the very powerful voices of the people that we care for and serve. I have no disclosures, but I am funded by the CF Foundation Schwachman Clinical Investigator Award. So contrary to previously really widely held beliefs, minoritized people with CF actually make up a significant portion of the CF population. So this is CF registry highlight data from 2024, which shows that over 10% of the population is Hispanic and over 3.3% is Black or African American. Those numbers are growing, and that's really owed to better diagnosis and screening and better recognition of CF disease, specifically in minoritized communities. In 2024, out of those being diagnosed, 23% were minoritized race or ethnicity. Despite being a good share of the population, Black and Hispanic people with CF continue to experience a greater burden of worse health outcomes. That includes lower lung function, higher incidence of Pseudomonas infection, specifically for Hispanic people with CF, and even higher mortality. And while the outcomes for people with CF have improved with CFTR modulator therapies, those therapies aren't available to all people. And we know that Black and Hispanic people are less likely to have genes eligible for modulators. These are actually old data, and newer data is coming out, but the gap is still substantial. So there is some work trying to understand the experience of people of color with cystic fibrosis disease. Jessica Hudson and Christina Roman published the Communities of Color Focus Groups report, and these were focus groups that looked at the needs of communities of color, specifically in our interactions with the CF Foundation and information about CF. And people talked about wanting visual representation. They wanted to see people who looked like them in materials, on websites, in information about cystic fibrosis. People wanted real engagement and to feel included and not just be a token minority in a group of people. They talked about representation in data. So despite small numbers, they wanted to see health outcomes for their groups and also to be included in clinical trials specifically. And they discussed cultural competency training and sensitivity training, and these are just a few of the findings there. But what we wanted to really understand was the experience of minoritized people with CF in the healthcare setting. We wanted to hear personal narratives about CF disease and their experience with CF disease. And we specifically wanted to understand the influence of identity and community. So we conducted qualitative interviews, engaging those who personally identify as Black, African American, or Hispanic and Latino. And usually critical approaches will actually focus on just one group of people, but we found that there was definitely individuals who identify with multiple communities, so we wanted to include everybody. We enrolled adults with CF from across the United States and also through Community Voice, and we performed all interviews over Zoom. We conducted interviews until we had no new themes identified and we reached saturation. The frameworks we used specifically were critical race theory and intersectionality, and I'll go into what those frameworks involve. We coded inductively and then generated group themes based on those codes, and we validated those codes with a larger group of researchers as well as CF community members. And throughout the whole process, we did a process called reflexivity, which really includes how research or positionality, how your identity, your life experiences affect the data that you're interpreting. So the frameworks we used here are critical race theory, and that says racism is systemic. It's built into infrastructure, institutions, laws, government, and race and racism are central to understanding inequities. Also that race is a social construct. Intersectional approaches really get at how multiple systems of oppression overlap, and you'll see more of that definition in the findings of our work. So these are the people that we engaged in interviews. They had an average age of 33. We had the majority of participants were female, 75%. This is the race and ethnicity breakdown. And we had several different geographic regions included across the US, but the Pacific includes specifically Washington, Oregon, and California. So these were our themes. And isolation is really a theme that is coming up in a lot of our qualitative work. Another theme was intersectional identities, built from that framework that we used, specifically trying to understand the experiences of Black women with CF, not being heard, CF disease in communities, specifically Hispanic and Latin communities, and then advocacy and being seen. So the theme of isolation kind of continues to come up, and it's really the idea of being a minority within a minority within a minority. People talked about being the only person in their community, among their family members, among their friends who have the disease. Other people didn't understand the disease experience within their home lives and personal lives. And then they went into clinic and saw a lack of other people of color at the sites, including patients and providers. So it was an experience of loneliness in these two realms that really was important. One participant said, "When I see them all, they're all white. None of them look like me. So that's really hard." Another theme was that of intersectionality, built from the framework we used. So people talked about that having multiple identities that impact their experience of CF disease. And that includes, but isn't limited to, poverty, education level, gender identity, sex, disability. One participant said they, Hispanic immigrants, can't read well. They left very young and didn't finish school, or didn't really do much schooling because of the fact that they had to work when they were younger. A lot of people started working at 6, 7, 8 years old. That's just a normal, common thing, so they don't go to school. So this was a participant talking about the experience of being a Mexican immigrant and not having access to education because of poverty level and their experience moving to the United States. And then literacy impacting their experience of CF disease. And so it was these multiple different identities that were powerfully influencing their experience and understanding. A specific sub-theme within intersectionality was the experience of Black women with CF, which historically has not been highlighted, historically and really presently. What women talked about was that there was no understanding of their experience within mainstream medicine and even within CF healthcare. They talked about wanting to know what's important for Black women with CF. And they talked about a lack of understanding, of being understood. One participant said having different body image expectations as Black people, having different standard of beauty than white people do, and then contrasting that with what happens to your body when you have CF, which is being very thin, being bloated. That issue is more specific to Black women, as opposed to where the standard is just being more thin, or just being thin. They also discussed specifically about the very acute knowledge that there were worse health outcomes for them. And this is specifically in gynecologic and obstetric care. And people really wanted to know more about women's health and how that impacted them. One participant said, "I've heard that non-Caucasian women have a harder time, 1, getting pregnant with CF, and 2, they have the likelihood of having a harder pregnancy, sometimes resulting in miscarriage." Another theme was not being heard. And most participants talked about their experience receiving a late diagnosis and having to jump through multiple hurdles in a system not built for them in order to get a diagnosis and the right diagnosis. And they talked about, even after getting a diagnosis, having providers specifically outside of CF, so in their interactions with the emergency room, with the hospital staff, doubting their CF diagnosis because of those long-held misconceptions that CF doesn't affect minoritized communities. And finally, they talked about their symptoms not being taken seriously and not being trusted in their experience of CF disease and in general. At this point, I could barely breathe, and I still was not being heard. She, the CF physician, had to advocate for me at one point being pregnant because I was not being heard either. Lots of microaggressions, lots of passive aggressiveness, and different expectations placed on me versus white patients that they've had. There was a theme of the specific experience of Hispanic and Latin communities with healthcare. And I think this is really, really important. People were talking about having less access to care, and that actually means less opportunity to gain trust in doctors. And then less opportunity to gain trust in doctors means you don't want to access care more. One quote was, "They work in fields which doesn't provide much insurance. It won't cover everything. So a lot of people don't go to doctors. They try more natural remedies." For Latinos specifically, if they don't go to a doctor, they just won't go, talking about that cycle, the recurring cycle. But there is opportunity to empower Latin and Hispanic communities if it's done well. One participant said, "I was really shocked to see the amount of immigrant families that had children with CF. And they don't even know what it is." So I think just advancing that education to reach a lot more Latin communities, I think that's really important. Because I think there are a lot of minority groups that have CF that are just ignored and overlooked. And finally, it was the theme of advocacy and being seen. And this includes a lot of different types of advocacy. There was the self-advocacy of having to jump through hurdles in a system not built for you, but also the opportunity to be an advocate if you are a CF provider and if you care for people with cystic fibrosis. And really the avenue to do that is to understand the patient beyond their diagnosis. People talked about being treated as an individual, having providers ask questions about them beyond their symptoms or their healthcare needs, and that as a way of building trust. And people started to see me for who I actually am and not who they thought I was or how they painted me. I feel like because of where I live in South Central, there are a lot of people of color. So I feel like at least since I got diagnosed, I feel like my care was accommodated. My parents were also included in the care because they only speak Spanish. So I feel like I was always surrounded by doctors or at least somebody that could explain it to me and my parents equally. And this is talking about that opportunity to actually have a community for patients and provide support and how important that is. So out of a few findings, these are really what we thought were the most important. There are other identities that impact the experience of CF, like sex, like gender identity, social class, education, poverty, and all of them work together to really impact how somebody accesses care and is able to access care. Racialized experiences certainly still persist and affect trust as well as access. And then access to healthcare is an opportunity to gain trust, thinking about that cycle of access, built on opportunities to trust and then accessing care again. And then we have a chance to learn from communities and centers who are doing well. And what we saw were that where the communities were larger, people actually had a supportive environment that was that understood their specific identity. There are a few limitations. The majority of participants were women. The interviewer was a white cisgender female, which may impact the level of comfort to share experiences. And we had small numbers, which certainly means that not all experiences are represented. And with that, I want to thank the collaborating study centers, as well as my mentors and staff and the people who we had the opportunity and honor of interviewing. And I'm supported, and also the CF Foundation for supporting this work. And please email me if you have questions or thoughts about the research.
We have time for questions.
Amazing work, and it's really important and impactful to see those quotes, the way that you laid them out. I think very clear that we have a lot of work to do as a community. And just as an aside, we have similar themes coming out of our Pride CF work, looking at gender and sexual minorities, looking at very, very similar related kinds of topics. My question for you is actually about how you were successful in getting people to even engage in these interviews. Because we know from your work and others that people of color in general are less likely to participate in trials. So I'm wondering if you can talk about the strategies as a researcher that you took to work with these centers to get these people to agree to do these interviews, how that process unfolded, and also sort of what you learned from that. Because I think, you have now elevated the voices of people that were willing to talk, but there clearly are probably others that are either unable or not interested or afraid to share their stories. And I'm wondering what we can learn about your approach that you took that was able to do this, to then think about how do we approach and get the perspectives of others as well.
Yeah, absolutely. Thank you so much, Greg. CF community voice was actually really important. And I think there's this long held thought that the people who participate in community voice are the people who are consistently also engaged. And I think that's actually there was a wide variety of people who were more or less involved in medical care just through that community partner organization. And I think with CF, there's not one community, right? It's multiple people across the United States who have more or less support, more or less isolation is a big theme we have here, right? And so I think having a central community partner organization and really tapping into that is really important, because in that way you're building that community-based participatory research, which we actually talk about in a lot of other fields, but don't talk about a lot in CF specifically, because I think there is that lack of community. But in order to do community-based participatory research, you have to have that investment long term. And so having a kind of a consistent presence of a CF partner organization, I think is so important. And I think a huge part of the success and really tapping into that and partnering with programs like Community Voice. And then honestly, you see the participating centers up here, absolutely stellar work from the research coordinators. These people are so involved in the community. And when I met with them, they were I know who I want to ask. They weren't people who were historically already participating in research, which was huge. And they were I have a relationship with that person, and I really think that they'll have a lot to say and important things to say. And that's why we really got a huge wide breadth of people with very different lived experiences. And so the study centers is really important, and strong engagement with the RCs. So I think those two really, I really want to advocate for strongly building those partnerships, because that's how you reach and how who needs to engage, or who you need to engage with more as far as patients. And then I know this was a very long answer, but the last plug is that people are afraid. I had a patient or a participant who was I would like to say things off record about the experience of being an immigrant in the United States. And people are not. As the policy changes came into effect, there was a very clear slowing down of people who wanted to participate, or felt they wanted to, but felt comfortable to, and were accessing the centers. So.
A very quick follow-up to Greg's question. How long did it take you to interview those 20 participants, to recruit, to, I think
Yeah.
this is really important to know.
Yeah, actually a long time. It was a period of like 10 months, over like 10 months, because that's how long it takes to trickle, to like resubmit. I will say very briefly, a few months for the community voice participants because they were immediately kind of recruited.
And time for just this one last quick
Last one?
question.
Yeah.
I'll speak fast. So we did a similar survey among Southern California. Children's Hospital Los Angeles is 60% Hispanic.
Yeah.
So UCLA, I'm not quite sure in the same. UC San Diego, half the physicians are now Hispanic who are seeing the patients. But I think the most telling remark was a social worker said, when we talk to our white patients, we talk about ice cream, we talk about movies, and we talk to our Hispanic patients, say, did you take your crayon?
Yeah.
So the racism has to.
That's it. And that was this experience of like, can you just talk to me as a person? As that last comment. Thank you.
Thank you.
I'll let you introduce yourselves. Yes. Okay. Yeah.
Okay.
I'm now excited to introduce Diana Marangu and Leah Ratner for our last presentation.
Thank you for this opportunity. As the last speaker talked about, being seen, we are appreciative to the organizers for seeing the international community in this presentation. Leah and I are presenting, and I don't know if this is your disclosures.
Can everybody hear them okay?
Okay.
Not, okay, yeah.
Should we move it
Yes,
closer?
perfect.
Can you hear now? Is this clear? Thank you.
Thanks.
So Leah has some CF grants. I think they're not displayed in this disclosure slide. I have none. I have no relationships to disclose. So we're here to speak about building a Pan-African collaborative network for CF. And these are our early lessons and shared priorities. This is work done by a group of people, a large group of people, mainly from the continent, but also globally, as you see here. So we know CF remains significantly undiagnosed in Africa. And there's emerging data that suggests that cystic fibrosis is actually more prevalent on the African continent that has been historically acknowledged. So there are a number of gaps and in understanding the CFTR variants, and especially in underrepresented populations, particularly in Africa. Here we show the global map of our Pan-African CF network. This network was initiated in the year 2024, that's last year. And as of this month, we have 52 members who are communicating on WhatsApp regularly. These members are from 13 African countries and 19 countries globally. As you'll see on the scale, what is blue are about 1 to 2 individuals or participants from the network. So like, for example, I'm from Kenya. But then you'll see north, you have more participants. The yellow is around 8. And you do see that there's representation from America. And Leah will talk about how she started this network, and the other countries like South Africa in maroon or purple here. So for this work, we engaged members in the network, and this was a participatory approach. So a Red Cup survey was created. It had 42 questions, and we wanted to know what are member priorities. We wanted to know if we could engage members in terms of registry capacity, how do members want to communicate, and how do they prefer to be led within this network? So this survey was in both English and French, because we have a Francophone community in Africa, and it was disseminated via email and WhatsApp in March this year. Because of the few respondents, we opted to have more of a qualitative analysis of our data, and it was a hybrid thematic analysis, deductive from these aspects that I have shared with you about priorities and capacity, but also inductive, because we were able to read in themes that were important for respondents. So as of March, at that time, we only had 41 members, and 19 of these are the ones who responded. 12 of the 19 respondents were pulmonologists, pediatric pulmonologists like myself, but we also had internists, we had geneticists, researchers, and medical trainees who responded. When it came to the priorities, our key themes are shown on this graph. To show. So about 17 out of this 19 mainly spoke about collaboration. Collaboration is key. Collaboration to share resources, collaboration to mobilize funds, and also to build a registry. The second important theme here was around diagnostics and treatment. Sweat testing, genetic testing was seen to be important priorities when it comes to diagnostics and access to modulator therapy. Thirdly, we talked about, a major theme that emerged was around research and clinical capacity. And members were keen to have capacity improvement when it comes to clinical diagnosis for CF management and also research methods. Finally, advocacy was also one of the themes that emerged in terms of members' priorities, to engage with individuals from families in our institutions and to raise global awareness as we are doing right now.
Thank you so much, Diana, and thank you so much to the session organizers for inviting us here today. As I will continue with this presentation, I just wanted to briefly reflect on my own reflexivity and positionality, recognizing we are both speaking on behalf of the entire network. I wouldn't be here if I didn't have an American passport. We recognize it is a difficult time to come to the US, and we're happy to have this opportunity to speak on behalf of the entire network, but this is definitely not our work alone. So some of the additional recommendations that came out of this participatory survey, which we did in 2 sections, and it's fun to follow another participatory methodologist here, but so it was very, very important that we find sustainable funding, particularly for CF diagnostics. I think that's been one of our key motivators from the beginning, thinking about how do we diagnose and treat more on the continent. People ask for structured but flexible meetings, and meetings that allow for some skill building, recognizing that we know CF is already a rare disease, but it's even rarer in this context. So building upon already robust research skills, but thinking about how some of those clinical skill building things can happen as well to help with early recognition of when to screen. We needed transparent communication and feedback systems and advocacy grounded in equitable diagnosis. We have been working really hard to try to think about how to engage patient partners, but recognizing that is a hard thing when there's been very few confirmed cases across the continent. So we've been thinking about global allies, other patient partners, some of whom are here today, that have been really helping us think about the advocacy. So our overall goals are to strengthen diagnosis, as I mentioned, strengthen care, collaboration, and visibility for CF across Africa. Just as has already been mentioned in this during this session, there's very little visibility of CF for people with non-dominant identities. And so the continent of Africa can be sort of seen within that, where CF is often thought to be predominantly from Northern European ancestry, so really trying to bring advocacy to that. So here is our website. We encourage everyone to visit. Our posters also have the QR codes, but if you can't remember, it's cysticfibrosisafrica.org. And we have our four main pillars that came out of our participatory survey. And this is how we've really guided the current version of our network, though we recognize it's always going to evolve and change. So we have our first big arm is our research arm, and standing a year ago, I never would have thought I'd be able to say this, but we currently now have 2 funded projects, one of which we have to thank for the CF Foundation, and another, the Spirit Project, which is run by Dr. Hugh Gabriel, and I will acknowledge Diana as one of the site PIs, that is helping to expand capacity for genetic testing across the continent. And the other is our work in Ghana that's looking at implementation science for sweat conductivity testing for early recognition. We're going to speak more about our registry development at a later presentation, but Dr. Marco Zampoli is leading that, and we are working with his South African registry and migrating the data over to a Pan-African registry, and we've included different ways to incorporate coded data so PHI does not leave the country and the centers themselves, but rather creating a standardized registry to share data. I want to acknowledge Dr. Sarah Wardy, who has been really doing an awesome job championing the clinical part. Again, recognizing that CF diagnostics are rare and in many contexts. And so thinking about challenging cases together, she's been running a monthly case conference, which we intentionally don't record because we have to protect PHI, but would love if anybody is interested in presenting or collaborating. We always are looking for cases where they've been diagnosed in particularly resource constrained or resource denied settings to think about mutual learning. And lastly, our advocacy arm, which I think is our newest, and we're still building, as I've mentioned. We're trying to partner with either patients from the diaspora or global allies that can help inform the lived experience of CF in resource-constrained settings. So this, I'll say, is also part of our advocacy. As part of this survey, we recently published a call to action, but also an invitation to collaborate about our network. So you can see that in the Journal of Cystic Fibrosis. This was a word cloud that we developed when asked, what is most important to you in the network? And as you can see loud and clear, as Diana mentioned, collaboration comes through. And so we've really been trying to focus on how to do that and meet each participant where they're at. So in conclusion, our network, the Pan-African CF Network, has emerged as a platform for collaboration. We're trying to ground it in lived realities and also harness the robust professional expertise that exists across the continent. We want to call on everyone here, all global health actors, funders, and CF organizations to recognize this critical opportunity that there's a continent that needs support in thinking about how to diagnose CF, and that it's not only possible, but we really see it as essential for truly global understanding of this disease, to also understand CF in other contexts. So come visit our posters. The QR codes for how to get in touch with us are on both posters. And we also just wanted to highlight other presentations from our network. Dr. Samia Nasser is giving several presentations. Dr. Amit Euler also giving the plenary tomorrow. And we have lots of posters from lots of our different participants as well. I want to acknowledge Dr. Chandra's and Grace Hennessy's, and several other posters by Samia as well. This is our group. So again, speaking not on behalf of just Diana and I, but really of our larger group. I wish they all could be with us here today. And that's all. Oops, sorry. Thank you so much.
I saw that you come. I think there's.
We also had a video that we would like to share with you from one of our network members. Thank you.
I'm just looking to see. Okay.
Hi, today I'm gonna tell you a case. She's recently diagnosed with cystic fibrosis. Unfortunately, here in our hospital, Abu Sitta, this case is Tajawi. She's a Libyan female. She diagnosed with cystic fibrosis and heterozygous type. The patient has difficult and recurrent pulmonary infection due to Pseudomonas colonized in her chest. Her story starts since childhood. She is a sibling of twin. Even her sister have the same issue. But the thing is, we don't have a mutation gene test to be done for all the family members. Therefore, I only did for the most severe cases, like Tajawi. She is having a cystic type bronchiectasis, moderate in severity. The patient has this year a recurrent pulmonary infection due to her Pseudomonas colonized bacteria in her lungs. The patient needs help. The patient needs inhaled antibiotic. We don't have. The patient needs medullary cystic fibrosis drugs. I'm gonna tell Tajawi the video. Tajawi, she's gonna tell her story. Okay, now this is Tajawi. Please support our African Cystic Fibrosis Network for her to get all the treatment that she needs. Thank you.
Yeah. Thank you. So that was from a hospital in Libya, and I just want to acknowledge Dr. Arij Dakshi, who made that video and really wanted to include a patient voice. We tried to translate that she was speaking in Arabic, but she started crying right in the beginning of the presentation, or in her conversation, so that we couldn't translate it. But thank you for watching, and thank you all for being here.
Do we have any immediate questions regarding that presentation?
Thank you so much for your presentation. I'm curious how the 13 countries within Africa were determined to be part of this network, and is there work to look at other countries in Africa? Because obviously it's a very giant continent, and I'm sure there's other places where people are undiagnosed.
So thank you for that question. Actually, everybody on the continent is invited to participate on the network, in this network. So we've used our different, how would I say, organizations in which we are in to reach out to anybody who'd be interested. So everyone in Africa is welcome. Thank you.
Yes. Thank you, Diana. I'll just add to that. This really was the brainchild of Dr. Hugh Gabriel and Dr. Marco Zampoli. And I wish they both could be with us here today. But when I joined them, Marco actually has trained a lot and is very well connected with a lot of pulmonologists across the continent. So we started by individually reaching out to each of his past fellows. And then through that, created word of mouth. But beyond just the continent, everyone is invited to collaborate. I mean, across the continent and allies alike. So yeah, thank you for that question, Melissa.
Well, we looked at the registries in Canada, Stanford, United States, just for India. There's probably 130,000 patients with cystic fibrosis in India. Mm-hmm. Do you have any estimate? Because you've got obviously French and German, and there's a lot of different
languages.
ethnicities as well. So do you have an estimate for the total number?
It's a really tricky question. We suspect that eventually we'll probably have a similar incidence. However, it's very hypothetical, and we've been doing calculations for projections, so I can't say for sure. Yeah, I cannot say. So do you know the exact number? Yeah.
It's not number, but there was a nice.
How much best do you need?
So we.
How much Toby do you need? How many best?
A whole lot.
I'm really just in testing for sweat chloride. That's really.
Well, sure. Yeah. So just to speak on that, there's an interesting map that's been put out there, and it looks at the total live births on the different continents. It's showing in the subcontinent of India, Africa. So in 2022, there are about 45 million new births. Now, the incidence for cystic fibrosis, for example, in Europe and the US, I think is much higher, like 1 in 4,000. So in Africa, it would be maybe, much lower, like 1 in 15,000. But with absolute numbers of the births, you see the proportion will tend to be bigger. If you look at 45 million new births vis-a-vis 4 million new births. So we think it may be more, we don't know. And this is really an opportunity to actually look for more of this data. We're looking at, I don't know if Leah, you had talked about the systematic review we're looking at and trying to scope and just see what is out there. And then we need to, as we said, collaborate, do more sweat testing and more genetic testing. And we'll soon maybe have better estimates to report. Thank you.
I will recognize that both of the funded studies that we both are just starting now will increase our ability to make diagnosis as well. And the map that Diana is talking about will be in a presentation on Friday, so I'll plug that as well. But it was just a lot to talk about today. But thank you for that question.
I think at this point in time, we're going to actually invite all of our speakers to come up and open up the questions, because I think there's a lot of cross collaboration and ideas. So you can have a seat. Yes. Just ignore my yogurt cup.
I'll just eat it. I'm just kidding. Thank you. Yes.
Okay, other questions?
Oh, yeah, just regarding the last presentation, I'm a huge fan of Marco Zampoli, by the way. I've been following his registries. And so I'm the president of CFE4L. We provide help for over 600 families in the world, mostly in low-income countries. We've helped families in Zimbabwe, South Africa. I've worked with Marco Zampoli, and just incredible. And he is, yeah. I'm not worthy to be at this microphone. That's how powerful he is.
We think the same.
Yeah. But what I'm trying to figure out, because we're actually addressing these needs in sustainable programs beginning in Mexico City, we're trying to meet the evidence-based care basic needs. So what we're trying to do is provide enzymes. As you know, there's a worldwide shortage, and we're doing it. Awesome. And the research we're doing is looking at cost efficacy, right? From my background in finance, we're saying, like, if you give them enzymes, people that have never had enzymes, can you reduce inpatient, reduce one inpatient for every 25 patients per year? And I would love to do, we have worked with people in Ghana. We always work directly with doctors, not directly with patients. So, we build a relationship. But I would love to do a similar project. And we can get funding.
Thank you.
Let's
work together.
I mean, like Ghana, we would be very interested in that. There's some challenges, but what I would like to do is, I also really into social media because I have to raise awareness all the time, because this is the only thing we do, and it's hard to get people in the United States to see CF through the lens of people in these very poor countries. So I've been trying to kind of get a handle on what is the enzyme available in South Africa, because there's a lot of evidence in Latin America, Middle East, but I don't know what it is. And every time we've done it, they've told us no one has enzymes. Is that? I know Dr. Zampoli has them, But I mean, does anyone in South Africa, right? So, but does anyone else, like, is that true?
Yeah. Sorry, you might not be. Maybe I stand. Okay. There you go. I can't see him. Oh. Maybe I'll just stand here. I'll stand here just so that I can have. So there are access programs in some certain countries in Africa. For example, in Kenya, there is an access program that patients who have CF can tap into. But I can't speak. I don't know about all the other different countries, so I don't have that information with me
Is
now.
access paid for by the government, or is access
It's paid by a company. So they like for example, there are access programs that perhaps like a company would collaborate with a different NGO, and then they have access.
Okay.
Thank you.
Yeah, I'd love to talk to you more because I just think we can really do something there. So
Yeah.
thank you.
Thank you so much for that question, and let's talk more later offline.
We have another question in the app, and it says for the BCH, for the Boston Children's Hospital pharmacist, since we're very medication focused clearly today, I wonder if the limitations in 340B provide an opportunity to compare the impact of those who can use the mechanism versus not in your and other centers. I realize there will be confounders, but could it be informative?
Yeah, I think absolutely that would be very informative. This project was a little smaller scale and right when we were starting off, but I think there's huge opportunity for investigating that further.
Thank you all for incredible presentations. And I'm going to ask a question about the elephant in the room that we've sort of skirted around. And we've talked a lot about populations of people that we care for or we want to care for that might have limited resources or limited access. We've talked a lot about sort of the challenges in structuring a care team to provide those resources. But I'm wondering if anyone wants to comment on the big problem of the fact that CF care is so expensive. And we have a huge cost driver that we all know, which is the modulator therapies, that, you know, we could set up the best system possible for all of our patients with disadvantage. But if the system says a drug is X hundreds of thousands of dollars a year for 70 years, what can we start continuing to do about that? I'm just curious. It's not a new question. It's sort of a question that I think overlies a lot of the work that we've already talked about this morning.
I don't think there are any volunteers in this group. Yeah.
Great question.
I think that it's an important one for us to all think about because we could pour all the resources we wanted into social work support or better diagnosis or improving our efficiencies. And we need to do all of those things. But if payers and manufacturers are putting up roadblocks, I mean, I think this is where we need to share these stories and see if we can make some inroads. I mean, Jamie, you may have some opinions on this.
So I will tackle the elephant in the room. I think it is us going back to our advocacy, going back to the CF Foundation, and I know that the foundation has done work, but how do you, this is unfortunately an age-old problem of how does David take on Goliath, when Goliath has a lot of money. And I think honestly, looking back at when David has been successful at taking on Goliath in the past and trying to tap into those, actions, our voices can be loud, and we can make them even louder. Coming together, last year at the conference, because it was in Boston, there was a small group of people that walked over to Vertex, and our voices, we started putting our voices together, but I think our voices need to get louder, both from the foundation, but from all of us, from our patients and us as the care team providers. And it's not going to be until we are screaming at the top of our lungs and we make it very hoarse, and get a lot of headaches from banging our head against the wall. But this is what I think is going to take to make change happen in the current climate that we have, and perseverance.
I actually wanted to add something, a question to Greg's question, how do you fix a health system that inherently inequitable and it can't fix itself from within? And why is the health system, us, tasked with fixing issues that originated way outside? We are tasked with fixing societal illnesses. We're not set up to do that. We can band-aid and patch up and ameliorate things. We can't fix the issue that generates those social needs. People have those unmet needs, whether they have CF or not. CF exacerbates it, obviously. But the problem, from where I stand, is not solvable from within the walls of the healthcare system. And if we really need a permanent solution, that's what we need to shoot for. And it's taxation, policy, coverage, and all of that.
Sorry, go ahead.
Yeah, just to piggyback off of that, I think that's something that as social workers, we all have experienced, which is there are these larger social drivers, neighborhood and built communities where I live in Charlottesville. Our public housing stock is all well over, 80, it's 80 years old. The conditions of that housing that are affecting, there's mold in there, there's constant flooding, the elevators are breaking down. People that are living in those environments obviously don't have access. And we do spend time and energy trying to partner with community organizations to improve that. But I would also just like to say specifically around the insurance piece, I think for a lot of people, a really critical moment of advocacy is coming up. If you, like me, live in a state that has a part-time legislation or your state is only available part-time, Virginia, we only run from January to April. So when laws are passed on the sort of national level, when budgets are cut, when Medicaid funding is cut, we don't have the opportunity to respond to that immediately. So I would just put a plug in for now is the time to start bugging your state representatives and your state legislatures. Now is the moment to start working with your state or local chapters of the CF Foundation to provide targeted advocacy efforts, because if we can't get federal funding for Medicaid, then our state of Virginia currently has a trigger law in place that they will unenroll some of the people from Medicaid if they don't decide to make up the funding. So from January to April, I will be talking and discussing that at length with our representatives. And I have several patients who I've helped write letters and stuff to do that so they can provide personal testimony. So if you're in Virginia specifically, come find me. And otherwise, you can look up on the CF Foundation website. They specifically talk about what states and who is at risk of losing their Medicaid and some of this really critical coverage. So if you're wondering if you'll be affected, the foundation can tell you.
And I can also add, to tag on to your comment, there is two very unknown bills that have been introduced both to the House and to the Senate. They've been sitting on the books for years now, but they are basically, they are called the Medicare for All bills, and would effectively, if ever brought to the floor, which I don't see happening in at least the next 4 years, would create a universal health coverage program for the United States, including basically a universal formulary and coverage. And one of the benefits to that would be now you have a very powerful representation talking to drug companies and the ability to say, no, we are not going to pay that. And that may be the only thing that ever really gets a successful conversation happening with drug companies to lower their costs, both for CF and so many other chronic illness. Our CF patients with diabetes are having some of the same conversations related to insulin, a drug that is incredibly cheap to produce. But we have millions of people across the United States having access issues. So if anybody's ever curious, there is a great book titled Medicare for All that talks about the bill, what's happened to it, and exactly the pros and cons of such a bill in place.
I just want to make a plug for outside of policy and kind of advocacy in general, but I think it's really important to critically examine how our scientific institutions kind of throughout this whole conference interact with patient communities and don't interact with patient communities. And I think that science and medical care in general becomes an echo chamber that is limited to the people in this room. And so the thing that we can come out with today is to really critically examine that and how your own daily interactions with medical care and science contributes, and how our interactions with our institutions contributes, and how we interact with pharmaceutical companies and the things we ask of them and they ask of us. That's more on a organizational level. But I think it's that awareness that we have to bring into our work now and when we're doing it. So that's all.
What a fabulous statement to end our formal time on. I could not have said it better. Please, everyone, give a round of applause to all of our fantastic speakers. We are at time for this session, and recognizing that NACFC is constantly going, I know a lot of people probably have to jump to their next thing. I will be hanging out for a little bit, as will my co-moderator, but thank you all so much for coming to this early morning session, and thanks again to our speakers.
Great job.